Okay, thank you. Thank you very much for a nice presentation and for the invitation. So for some of you may know that I'm currently doing my third year of a PhD. I started 2 years ago with a master, and then I transitioned to the PhD under the supervision of Dan, as we said. And today I would like to present my progress so far. So, okay, so we spent, my project was divided in two major parts. The first one, the writing a scoping review on extended reality in, wrongly spelled, I apologize, in anesthesia education. And then the second part was conducting a randomized controlled trial comparing virtual reality and mannequin-based simulation for education in anesthesia, which we branch in two different, bigger outcomes measures. And then hopefully we'll have time to talk, to have some questions and answers. Let's start with the first part, which is the extended reality in anesthesia education. And this is a copy review. The idea is that extended reality or all forms of virtual reality are very popular, but we don't have a clear idea on how it is implemented in anesthesia, and particularly in education. So we wanted to answer these questions, which were basically about if the extended reality helps in knowledge adaptation, in improving anesthesia skills, both technical and non-technical, if it was improving, it has a positive impact in the participant in terms of confidence and satisfaction, and if there was any clinical outcome after a training with extended reality. The question is, so the scoping review was focused on paper published after 2010, focusing on all healthcare providers that were undergoing training in anesthesia-related field only, and we looking into anesthesia-related skills, both technical and not technical, as I said before, and we try to find also papers that were either explain the educational application or compare the extended reality with other educational methods. But what do we mean for extended reality? So there are different definitions, which is something that we may talk later. The definition I use is the extended reality is an umbrella that covers three different technologies. The augmented reality, where the virtual objects are overlying the real world, but it is not the user doesn't have any interaction with the virtual object and the real world at the same time, which is a characteristic of the mixed reality. So the augmented reality, for example, is something that you can see on your smartphone, as if you, for example, if you play, or if you play Pokemon, Pokemon Go, that's the case possible. Mixed reality, you still have the virtual object on the real world, but the user can interact with both, with the real world and with the virtual object. In the virtual reality, the way I'm intending now, is there is a complete separation between virtual and the real world, and the users is completely immersed in the virtual world. Now, it is important to notice that for many years, and you can still find the paper, virtual reality was embracing all type of computer-based technology that has some virtual software. And this wasn't a problem that we found in our scoping review. There is also another definition, which is where basically the augmented reality is covering actually the mixed reality and the augmented virtuality. So I'm not going to go into the details, but this does to give you an idea. There are many definitions out there, so it's very hard to make a selection, a cluster of this type of studies. That said, we screen over 5,000 abstracts, and then we selected about 290 full manuscript, and we included about 62 full tests in our scoping review. Except for about 80% where the trainee background was not specified, the other were basically divided in half. Half were focusing on anesthesiologists and anesthesia resident, and the other a lot of different specialties, including surgery, dental, dentistry, emerge, pneumology, cardiology, and so on and so forth.
I'm going to keep listening. Actually, I have to go speak with you about a patient.
Sure.
I'm very sorry.
No. So over these 62 articles, 24. So the way we cluster and we group our articles were based on the definition that manuscript used, not the definition that I gave before, and I'm going to go there in a couple of slides. So the augmented reality papers were 24. The mixed reality 4, and the virtual reality were the majority, which were 34 manuscripts.
So you did not include any to the screen-based.
I actually did, and I go there in a second.
Okay.
It will be then the next slide. So as you see, for the anesthesia-related topic, the majority of the study were focused on technical skills. Epidural placement, spinal procedures, peripheral nerve block, central venous line insertion, and then there were others with a few also looking at non-technical skills like ACLS and pulse training. The design of this study varies a lot. About 37% were randomized control trials. If you included non-randomized control trials, you almost reach 50% of half of the studies. In terms of most of them were single centers, so about 82%. And in terms of intervention, the majority, so is actually the line below, were basically using the extended reality for training and assessing the training after the use. Very few did a pre and post training, and very few actually they basically give the virtual reality, sorry, the extended reality, and ask the trainee how they feel about it. About 50% compare the extended reality with another training method, and other 52 did not. So here is what we were talking about. So as you see, because I used the definition that was reported in the manuscript, I found an important discrepancy. So here I'm highlighting the same extended reality tools was classified as an augmented reality, mixed reality, or virtual reality. Exactly. And if you look at, for example, the smart glasses, again, we're both augmented or smart or virtual reality, immersive virtual reality. Now you're asking about the computer base. Eventually, yes, because the definition is a little tricky. So if you look up on the virtual reality list, you can see there is the ORSIM. The ORSIM is a bronchoscope training. So it falls in our definition, which is an anesthesia-related skills that you want to look at. But it has nothing to do with a virtual reality or augmented, because you have your screen that is just reproducing the airways, and you have a bronchoscope. So that's the tricky part. So, and as I say, as I was just saying, so we have to include both immersive and non-immersive virtual reality. And this is what we found. So in terms of how the outcome were measured, I would say that all three extended reality tools were basically measured with an objective measure like checklist, or participant survey, how they feel about the use of this extended reality tool. In the augmented and the virtual reality, there was also a good proportion of study looking at the scoring, having the trainees scored by an evaluator. And the mixed reality was the only one having a two study where actually the technology was measuring the performance of the trainee, like measuring the time to complete a spinal procedure, so an epidural. So we compare, this is a busy graph, but let me go into that. So basically we want to answer our initial questions, which we are knowledge retention, technical and non-technical skills, confidence, satisfaction, sense of realism, sense of usefulness, and perceived workload. And we did this with the entire cohort of the study, 62, and with a smaller cohort, they were the one they actually have a comparing, they compare the extended reality with another method, so the 48% of the studies. These here, I'm reporting only those studies that were comparing the extended reality with another training method. As you can see, so the darker green is the augmented reality, the light blue is the virtual reality, and the light green is the mixed reality. So overall, the extended reality improve all the domains that we were looking into. But I want you paying attention on only these. So there were few, the minority, but few studies showing actually a worsening in knowledge retention, technical skills, not technical skills, and a realism with, this was only with the virtual reality, which somehow makes sense because first of all, the virtual reality, as we see, has a huge umbrella that it takes into account very different tools. And most of the time, especially for technical, non-technical skills, they were comparing to mannequin-based simulation, which is the second part of my talk. There was also a fair amount of bias in our field, in our scoping review. You can see I use the MMAT tools. So 13 studies, because they have a high risk of bias in the first two questions. I didn't complete the actual bias screening, but they were still included because we want to have an overview of what the tools that are available for the anesthesia, which is the reason why we did the scoping review compared to other type of reviews. So that's what we did. The study was submitted to the Canadian Journal and was approved last week. So this is done. Any question for this part before I move into the next one? Okay. Second part. Yeah.
So how many of the video of the virtual VR was 2D as opposed to 3D screen-based VR?
I can't remember from the top of my mind. I would say this would probably roughly 40%. We had to remove mainly the bronchoscopy training and a few studies on cardiac echo. So the other were all.
I understand. How can that be virtual when it's a bronchoscopy?
So the problem is, it's not immersive, it's not head mounted.
No,
So
I
that's
know
why
that.
we added that, right? So that keeps on coming back again.
So
This keeps coming back. That's why I'm saying that we got reviews and we got people saying, you better include the 2D. Maybe the 2D is just as good first and stuff like that.
yeah, that's a problem. And just to give you an example, in the last year or the beginning of this year, just before when we submitted our scoping review, there was actually a scoping review on airway management, so anesthesia, published in the Anesthesia and Analgesia on virtual reality. And the reality, they call it virtual reality, and they include any type of virtual software that was there. So basically, it was more similar to an extended
Camera.
It was like a bronchoscope with the computer screen or the immersive headset.
So laparoscopy is a virtual reality?
They do if they have a screen in front
Correct.
of you. Because it's virtually real in the screen, but not.
Wait, so radiology is on a screen too.
Right.
Just X-rays, virtual reality?
So that's absolutely a good
That's
point.
crazy.
But the
And-
definition changed from 2019.
That's the thing.
That's where the
You can-
cutoff happened, when
but-
all the others are not included in that.
Absolutely correct, but they are still, but there is a, you can see there is a big gap in knowledge and harmonization in
We'll just
definition.
ignore it.
Yeah, that's the
Alright.
main
Tell us
question.
about the good stuff here.
Okay, virtual reality about high fidelity simulation to train not technical skills in anesthesia. So the main reason is obviously high fidelity simulation represents our gold standard in training technical and non-technical skills. And we want to see if the simulation works well. The virtual reality works well. So just to a little disclosure, the module was funded by the McGill funds from medical teaching in clinical settings. Was developed with a local company called iGotcha. He received a first grant from the Society for Education and Anesthesia in 2022, and this year from the Canadian for the second part. I added, and I'm going to talk about it a bit. That said, as I say, high fidelity simulation is our gold standard for both technical and non-technical skills, but getting to the simulation center and simulation has a couple of problems. First, access. It is a problem because, as you can see here, on the left, you see the map of the simulation centers in Canada, and on the right, you see the hospital centers, and you can see that
That's a great one.
some of them are very far from simulation centers. So how you can get there?
You can, by the way, just take notes, you can get that same site, Society for Simulation and Healthcare, you can put instead of Canada, any area.
Yeah, I did for Philadelphia, for
You see,
Pennsylvania
because-
too.
This is such a great way to compare number of hospitals with number of simulation centers. That's a great visualization.
So that's one problem, access. Second problem are cost, but keep in mind it is based on evaluation between 2009, 2015, so it's 10 years old, so it might probably be much higher. So setting up a simulation center cost about $500,000 or even more. Keeping it a functioning cost about 60,000 or even more. So we have basically three problems. One is the access. We all knew very well, realized this during the pandemic. Then the space, you need a space, a lot of space, and a lot of people walking around, and you need a fair amount of money.
And what's
so-
in between? Actually, in between was also people.
Yeah, people. So you
That's
need
the other, that's the
yeah,
other big thing.
yeah, you need actors, you need proctors, you need technicians, you need people that
Right.
keeps everything open. So there is a lot of human resources and non-human resources. So in theory, virtual reality can overcome these problems because you just need a couple of people, as in our study. They train a room big enough to run your simulation. And in theory, it can be also less expensive than the mannequin base. So here I just got the slide, but basically you can see that it can cost about 1/3 of a mannequin-based simulations, either like an absolute number or per trainee. However, yeah, virtual reality is fun and nice, everybody wants to use it. But whenever, as a principle, when you implement a new technology, you need to see if it works. And that's why we decided to compare it to our gold standard, the mannequin base. So the project, the development of the module started actually before my PhD in 2021 and was completed in 2023. We pick up the scenario from the pediatric critical events checklist, which was an anaphylaxis scenario. And our null hypothesis was to compare virtual reality and high-fidelity simulation on a non-inferiority study. So the null hypothesis is that virtual reality is inferior to high-fidelity simulation to teach non-technical skills in anesthesia training. So this is the way we did. So we took our anesthesia trainee, we first stratified them by year, by seniority, and then we randomized in two groups, VR or high fidelity, which underwent the same scenario, only delivered either in the virtual reality world environment or in the high fidelity environment. They were assessed. Then after about 3 weeks, all participants regardless of the group assignment, who underwent a high-fidelity simulation. This time the scenario was different, and they were assessed. So what do we assess? So we start with the non-technical skills which have been validated in anesthesia, which are the Ottawa GRS, the MEPA GRS, and the ANTS. And we also wanted to evaluate their level of stress not only, and a sense of workload and emotion in general, because there is a disease bell curve where the trainee can be super bored and not learning anything, or super stressed and not learning anything. So we wanted to understand where they fall during the simulation. And we also use the heart rate variability to measure what you can call a physiological stress, if you want. So for the validity scales, as I say, Ottawa GRS, and MEPA GRS, and MTS. I'm not going to go into details. They basically more or less look into the same domains: situational awareness, communication skills, problem solving, and leadership. The Ottawa GRS was developed to target emergency room physicians. The ANTS is specific for anesthesiologists. The MEPA GRS has the advantage of being scenario specific compared to the others that can be applied to any type of simulation. In terms of perceived stress, so why we choose certain scales, and these are the reason. The state anxiety inventory scales inventory was chosen because it's a scale that goes from 0 to 100, 0 non-anxiety at all, and patient is a trainee is freaking out. And there are a few studies showing that by training the trainee, the anxiety goes down and the performance goes up. That's why we choose it. Comes with two scales. One is the trait anxiety, which means the anxiety that the trainee, the subject reported as a baseline. And it is also the state anxiety, which is the anxiety that the trainee has at that moment. We measure before and after the simulation. Then we measure the NASA task load index. Is validated by the NASA, is basically measure the perceived workload on a given task. Again, goes from 0 to 100, 0 very easy to basic no workload, under overwhelming workload. Usually is anything between 39 and 61, and it's been shown there is some correlation between the perceived workload and the anxiety. And the third one is, well, we focus on the anxiety, but at one point we say, well, maybe there are other emotions that can be interesting to look into. So we took the medical emotional scales. There is not much in the literature, so there is no clear threshold. This is the only study I found. Basically, there are 20 items clustered in 4 big families. 5, there is the neutral, but the 4 big families are positive activating emotions like happiness, positive deactivating emotions, relax or calm, negative activating emotions when you feel anger, for example, or negative deactivating emotions like sadness. And we want to see how the trainee express their emotion during the simulations. So for the physiological stress, we use the heart rate variability in breath. When you put like these ECG, the same one you can use on your treadmill at the gym, you can measure the change in the heart rate variability on a given time, which is normal. It happens all the time because of the sinus arrhythmia and because of the stress. So when you plot these over time, and then you use the Fourier transform, you can actually measure the energy of each band. So you can divide it in 3 big bands: very low frequency, high frequency bands. The high frequency bands is the one that depends only on the parasympathetic tone and is basically affected by the sinus arrhythmia. And the midline, the one in between, the low frequency, which is the green one, is a balance between parasympathetic and sympathetic tone. So there are a different type of information you can get. The one that we use was just the low frequency high frequency ratio, which means that the a sort of sympathetic parasympathetic balance. Why? Because there is some information in the literature that our baseline when we are relaxed, it should be about 2 ± 1. And when we are doing the simulation, this goes up to about 4 or so. So it might be a sign of physiological stress. We also wanted to know if our model actually worked. So we did so by asking a ad hoc survey, by measuring the system usability scale scoring, which is used to measure a new technology. Goes from 0 to 100. Usually the median is 68. Anything above 70 is considered useful. 68, between 65 and 70 is considered a marginal high. And then we measure the technology acceptance models, which basically tells you, okay, I have this technology, I want to market it, I want to make it work. What are the 3 important factors? Are the perceived usefulness, the perceived easy to use, and the behavioral intention to use. There is no universal benchmark. In general, the company uses it to improve their technology before marketing. Anything above 80% is considered a good result. How we measure our training? So where we took our primary goal was the Ottawa GRS score. So we took the Ottawa GRS score after the second simulation, and we adjusted it for the pre-op, for the first simulation covariances. We did the same with the other 2 scales, and then we just did a descriptive statistic regarding the physiological and the perceived stress and the workload, and we also report the trainees' feedback about the VR. These are the tests that we use after checking for the quality of the normal distribution and the quality of covariance. We apply the ANCOVA for the covariances that we had in the first scenario. And for the first scenario, we measure these with the ANOVA instead. And we also measure the interclass correlation coefficient for our 3 non-technical skill scales. The sample size calculation was based on the study that I reported here. The study used only high-fidelity simulation, and after the training, they saw that in general there was an increase of the Ottawa GRS score about 0.6, which was our non-inferiority margin. We did a preliminary trial on VR with R5 trainees that they were excluded by the study, and we found our Ottawa GRS score and the standard deviation. They are reported. We put everything in the R software, and we come up with 12 trainees per group. And these are the results. So on you can see the 2 columns, VR and high fidelity, and VR in orange and high fidelity in blue. So no difference in age, no difference in gender, obviously no difference in seniority level, because this was already addressed before the randomization. They report the same amount of simulations as a leader. There were no difference in terms of experience in gaming, even though the high fidelity simulation was a little bit more. They play a little bit more in games than the virtual reality. And interesting is that if you look at the last 3 lines, the regular play video games was 0 in the virtual reality. There was only 1 trainee who had experienced VR. No, the other have no clue. We respected the 3 weeks simulation, which was not perfect because we had to take into account the trainees' commitments with the university. And in terms,
time is in weeks.
it is,
3.3?
yeah, yes.
Because you need to put it in. It's right now. It's not clear at all.
Yes, you're right. It is in weeks. And the virtual reality sickness questionnaire, which was done to see it goes from 0 to 100, and anything below 10 is considered a good result, was obviously given to only the VR group, and we had a median of 8.3, which is wasn't bad.
How many were sick because it went up to 14.1?
Yeah, so but the questionnaire is a continuous scale, so there is no clear cutoff in terms of, okay, this is a cyber sickness and not. I can tell you that because they had about 15 minutes of acclimatization with the same device or a different software. Nobody decided not to participate to the scenario because of sickness. Yes, so you can see there that we had to exclude 3 trainees because we only had the first scenario, which can be evaluated eventually, but we didn't have the second one. In terms of non-technical skills, let's go there. So here I'm reporting the overall Ottawa GRS. As you can see, actually the VR group performed worse than the simulation group in the first scenario, and then both groups, after adjusting for the covariances, show no difference in the second scenario. Why that? Well, first, one reason can be because the VR is not working well, and the two scenarios are not enough to see such a difference. That's absolutely a possibility. The other possibility is that the Ottawa GRS doesn't really perform well, or doesn't help the proctor, the evaluator in the VR environment. On the third, is it possible that the group didn't perform well because it was the first time they were actually doing the VR in this environment. I'm saying that because then if you look at the MEPA, the overall MEPA GRS, which is scenario specific, which means that there is much less interpretation by the evaluator, because the trainee has to get steps done on the within a certain time, given oxygen within 3 minutes, calling for help within 6 minutes. Well, the differences completely disappeared, both pre and post. And similarly with the NTS, which is like a midway between the two previous scales. Again, no difference before and after. So we don't. This is just to show you the interoperability, which all except the total MEPA GRS which we didn't use, were about 80%, so pretty good.
What do you mean you didn't use it, the MEPA?
The MEPA so we use the overall and not the total, because the total.
Such a big difference in the ICC between the two.
What do you mean? Sorry.
Yeah, 0.91 is the ICC for the overall versus the total. Why is it such a big difference between the total and the overall?
In this one?
Yeah.
Yeah, because what happens is that the MEPA GRS has a checkpoints, and then has an overall evaluation. The problem is that some evaluator check the points, made the calculation, but they didn't put each point to each item specifically. They just do like a technical skills. They cover these 4 points, so there was a lack of consistency in the evaluator inputting the points. So eventually you're gonna get a lot of missing data. That's why.
Should have used AI. LLMs would have taken care of that.
Yeah.
Sorry, do you have a question?
No, later. So the overall is the one that is much more reliable, because you have actually despite what you tell despite what you give in terms of points in the single questions, you check mark if the oxygen was given at the right time, and so on and so forth. Anxiety. Okay, anxiety. So here we use it as a continuous scale, which probably wasn't the right way, because it should be used as in clusters: mild, moderate, severe, super severe anxiety. It used as a continuous value. We did find differences, which basically means that most of the time the trainee after the simulation were a little less anxious, which is expected. But the differences are so minimal that I wouldn't say that I can't really tell that there is any value in these results. Some did also control for the baseline anxiety that I mentioned before, and the data were basically the same. The NASA TLX. Again, no difference between the two groups, even though the VR had a much bigger variance than the simulation, which is expected because they were not used to do this type of simulation in the VR. Interesting enough, in both groups, the NASA TLX was higher after in the second scenario compared to the first, which it was expected because the second scenario is much more complex than the first one. So, from my standpoint, this can be actually a way to stratify, to learn how to decide which scenario is easier or not, instead of going from with a personal experience. The third one is the perceived stress or high heart rate variability. Again, big variability in the virtual reality scenario, which is somehow can be expected, but no difference between the two.
But it's weird because the big variability in the first scenario, not in the second.
Yeah, because they were used to do actually
used to.
simulation. The VR
Yeah.
for some people can be
Instruct
really,
them.
yeah, they started hearing sound from everywhere, so it's much different and is somehow much more immersive. It was something that we found in our feedback survey. These super complicated scales summarize all the motion that we can measure. I highlighted in blue the differences that were between the pre and the post scenario in the two groups. Overall, from what I can see, because the motion scales are measured on a Likert scale, they go from 1 to 5, because in none of the cases except one, the natural emotion, there was no change of integer. The differences were within the same integer. I wouldn't consider that they are clinically significant. So I'm not sure if I can evaluate them in a different way, but this is something what we found.
Just you may not find anything anyway because it's hard, but still it's very hard to look at the numbers like this. You can't read them on the blue also.
Yeah, it was
the real fun thing would be if you could change this into one visualization with the 4 quadrants, and within each quadrant, rather than, I mean, you can put the emotion sort of faintly behind or something, and then plot your points somehow on in each quadrant, but it's gonna take some thinking.
Yeah, no, so that's absolutely possible. As you can see, in general, in both simulations, the positive activating and reactivating emotions like happiness and relax were much more predominant compared to the negative emotion. So that
I can see that. Where do you see that?
So if you look here, so I don't know if I can, I have a pointer, sorry for those who are online, but if you look at the first 2 lines, the green and the blue lines, those are the positive emotions, compared to the negative emotions, which are the
higher.
We are higher in both cases. That might be somehow, we can also look into a correlation between the performance and the emotion, but there is also risk that eventually you're gonna get into the researcher-wise error, and eventually you're gonna find something which is statistically significant only because you tried everything. So I'm not sure. I still have to decide what to do with this information. Moving on, that's the questionnaire feedback. In general, were positive most of the time. They found it realistic. They found that they were engaging. They found it a good way to train the trainees. But in terms of something more reproducible, what is the system usability scales? Well, the median was 68. Guess what? And the mean was 70. So we are just there, which is I have to say that it is in line with the other 2 studies that actually measure the system usability scales in virtual reality environment, which were 65 in one and something similar. So it is what it is. So
it's still an acquired
taste. The technology acceptance models, again, we were about 65 to 80 with a median, depending on the items. So this can be a good idea to have like a benchmark. So we are close to 80%. We are not optimal. We can still, there is still room for improvement. I believe it is the bottom line. As I said, we got an initial grant because we decided to recruit some more students. In theory, there should have been 14. There are actually only 7 from the University of Ottawa. The idea was to increase our cohort and also to see if the actual virtual reality is reproducible and what will be the feedback from a completely different environment. So the data I show you are all the the McGill. So I didn't include the Ottawa. I haven't analyzed them yet. We just finished to put the data in last week actually. In terms of timelines, since you were asked, so everything started in 2021 with the design, but my master started in 2022. We did our manuscript for the scoping review. We did our data analysis and experiment in Ottawa as a plan over the summer. And we are now I want to spend the next 3 months in doing the data analysis, and hopefully I'm going to start writing something in 2025. Sorry, I forgot.
Oh, sure.
There's bonus. That's to show you how the. I don't know if you can. No, you can't hear it. I'm sorry, you can hear the still there is at the beginning. There's the introduction of the environment. There's you can see the trainee point of view, the practice from on the laptop point of view, and our trainee is looking around. As you can see,
What's in the proctor's point of view, those dashboards?
So yeah, you can. So on the top you have some. You have 2 windows, close down windows, drop down windows. One is if the trainee goes well, you just click and you basically have a change in vital sign according to the script. If the trainee does something different, you have other options. Let's say that it doesn't give enough epinephrine, you have an option to change the vital sign right away. Or you can do, or if the trainee asks you for a medication or select a medication in the virtual reality environment, you have to approve it. The reason why you do that is because the avatar actually has to closes the loop by telling it, yes, I'm going to give you this medication, or are you sure, or this can be dangerous. On the bottom, you have the vital signs. So the vital sign can be changed with the preset on the top with the drop-down menu, or it can be changed manually if you are a little bit off what the trainee was supposed to do. On the right, which is probably the most difficult part, is that there are the dialogues. So there are basically so each avatar can talk can answer actually the trainees, and there are some scripts that we found that there at the end of the day. You don't have to use a lot of them, and there are different options. So you can select the avatar that you answer. You have and these are divided in 4 big categories, which are basically the common ones that you will use very often, the questions, the prompts, and then the 4th one I can't remember. There was something specific. So let's say that we decided only the surgeon can ask for. If you can continue the surgery, that's is in a different list. And then
Amazing.
Yeah.
Moving from automated affairs, the target creating more. Nice. Lovely.
Okay.